Thanks a lot, and have no disclosures relevant to the stock. So I'll present with the case who recently underwent a bypass and wasn't doing well, had a right great toe gangrene. He had significant disease, SFA, iliac, and he wasn't a good candidate for vascular surgery, so he came down to us. So he got his iliacs fixed. He had a CTO from his right common femoral all the way down to the SFA, and the only runoff was peroneal. So we went and we got distal SFA access because we couldn't penetrate from up top. We got it all the way up there. We realized we were in the false lumen. So, and then we loosened the plaque from up top. You can see the heavy calcification of the stiff end of a glide wire. Then we managed to get into the profunda. We IVISed it. We realized we're in the true lumen. So what we did was we went ahead and performed rotational atherectomy using jet stream into the profunda. That created a very nice lumen, and then we were able to get into retrograde. So with that background, so the simple reentry technique is what we do in coronaries. You go into the subintimal plane, and then you get back into the true lumen, and it doesn't happen all the time. So here's a case of a nasty popliteal artery CTO, very calcified, as you can see with the wire here. So we came in retrograde, and sometimes you find the right channel, loosen up the calcium, and you get right up top. And then here's another case where there's a AT CTO. Again, we couldn't get through from top, so we got access from below, and then we loosened the plaque, but we couldn't get down from below, but we created enough channels that finally we were able to get through from top. And in this, if you notice the runoff in the feet, you could barely see the AT, and it's important to remember some of them are functional CTOs, so we were able to get into the dorsalis pedis even though there was no flow because it was subtotally occluded with ultrasound access. And sometimes you got to pick your battles. Make sure you don't pick an unhealthy calcified segment because your sheet won't pass. So here's the cart and the reverse cart technique. So essentially what you do is you're not able to get into the true lumen from either side. So you have a wire from the antegrade and wire from the retrograde. So you inflate a balloon down from the retrograde wire, and then you try to poke through that. That's the cart technique. The reverse cart is you have the antegrade balloon up, and you try to poke through from below. This is the same thing in a schematic picture. And again, you just flip it. That's cart. So here's an example where we performed a cart. Just with the wire creating channels, the antegrade wire was able to enter into the true lumen. Here's the cart technique where the retrograde balloon is up and you poke through from the antegrade wire. And then here's the reverse cart where the antegrade balloon is up and you poke through from the retrograde wire. So here's an example of a safari, occluded popliteal artery. We couldn't recanalize from either way, but we knew we were in the same plane, and then we went ahead and snared. So usually I like to use an EN snare, which is multiple loops as opposed to a gooseneck snare. So there's more probability of getting into it. So how do you perform this safari below the knee? So here's an example where we couldn't recanalize the occluded posterior tibial arteries. So they snared from the retrograde micro snare. Here's an example of an occluded left anterior tibial artery. So what we did was you have a balloon up in the antegrade. So you're creating a reverse cart, create enough channels, and then you push your wire through, and then you snare it up. Here is a technique to use Outback to recanalize the posterior tibial artery. So after you get retrograde access, you have a balloon up from the retrograde, and then you use your Outback to poke into the balloon inflated in the posterior tibial artery. Again, be very mindful. You don't want to risk any surgical zones. And here's an example on the far right-hand side where you try to push the wire out and then try to snare it. So this is just a picture, cartoon representation of how they do the Outback safari. So essentially, you have the retrograde balloon up, and then you aim the Outback into that. And this is an algorithm which I think was presented in one of the previous presentations in a different conference. So a reverse cart, you start off with the retrograde, and then double, and then finally you can try the Outback. Here's another approach, transcollateral, where you go through the collaterals, puncture through the distal cap, and then you snare up. Use a mother and daughter technique catheter, so you have support. And similarly done for below the knee. And once it's externalized, and then you work through that, make sure you leave your support catheter through the collateral, because if you just have a wire and you try to balloon that, you might cause significant damage. And again, this should be attempted really, really late on after talking to your surgeon. So here's a technique where essentially you get bilateral retrograde access. You pass the wires up, and then you perform balloon inflation into the PT, into the posterolateral, to the popliteal artery, so keeping it simple. So it's basically retrograde axis. So here's a technique described by the Japanese. So essentially you have two wires. You have one wire with the IVUS and another wire which is your finding wire. And what you do is you kind of lay down your IVUS picture, compare it to the fluoroscopy, then you flip the IVUS and see how your fluoroscopy does. And you kind of use that to kind of try and wire into the true lumen. It's a little complicated. It takes a little while to get used to it. And here's a technique where this morning you saw Dr. PK trying to use transcutaneous ultrasound to re-enter into the lumen. And another technique is if the calcium is very, very heavy, you can disrupt it by poking and piercing. And Dr. Schmidt from Leipzig, they have described this. So finally, I want to conclude by saying that, try first things which are really common and comfortable and where you won't hamper any surgical zones. Try the retrograde approach. If that fails, try the cart and then the reverse cart. Just be mindful of the reentry zones. You can use reentry devices. Just be careful. You can use a combination of techniques. And I think it's time we approach some newer techniques. And finally, I think it's important that we work as a team. Thank you.